So, a very warm welcome to all of you. This is yet another event of our Celebrating Health Festival 2023, and I would like to welcome you on behalf of my other co-directors and the director of the Wilson Research Institute. Today we have three speakers. First of all, Dr. Li Ding, who is Associate Professor in Operations Management at Durham University. Her research interests include supply chain disruption and risk management, behavioral operations management, behavioral economics, and social sustainability and channel management. Then we have Dr. Dong Li, who is Reader in Operations Management at Loughborough Business School. His expertise lies in areas such as healthcare operations research, revenue management and pricing, choice modeling, resource allocation, and approximate dynamic programming. He is an associate editor of the journal Computational Management Science. And last but not least, there is Professor Christos Vassilakis, who is Professor of Management at the University of Bath and Director of the Bath Center for Healthcare and Innovation and Improvement. Working in close collaboration with clinicians and healthcare professionals, his focus is on operational research and management science. His research covers a wide range of topics, for example, the monitoring of surgical site infections, the organization of care services for patients with acute stroke, glaucoma, common mental health problems, and vague symptoms of cancer. The three colleagues will be speaking on maximizing patient benefit from triage policies for scarce critical care resource allocation during periods of intense pressure. Li Ding has already made the slides available, and we are all looking forward to a great paper. Li, the floor is yours.
Thanks for the introduction, and thanks for the invitation for us to share our experience and the findings of our work on maximizing patient benefits from triage policies. The work was actually funded by COVID-19 rapid response pool. Gladly, the pandemic has finished. We at a personal level all experience the pain in one way or the other. However, the lesson learned and the insights generated from our work, from our study, hopefully would be able to inform future. So that's kind of our intention today. So we, as mentioned, we have three presenters. So Christos will start and to set the scene and give our introduction and also the two important studies that leads to our project. And then I will take care of the problem setting, talk through briefly the approach, the model, as well as the hospital data we collected from one of an NHS trust, and also the questionnaire survey conducted among ICU consultants. And finally, Dawn will present the numerical and simulation results and wrap up with some key takeaways from today's talk. So that's the plan. So over to you, Christos.
Thank you, Lee. And yeah, so much of the work we do is a team that you see here that includes Navid from Bay School in London, and also Dr. Richard Wood, who's an advanced analyst and head of modeling and analytics working for the NHS. Next slide, please. So I'm going to set the scene, and I'm going to describe to you two studies that we run with Rich before we were joined by Lee and Dong in order to continue with the third project that is the main content of today's presentation. But I'll take you back to probably painful memories at the very start of the pandemic. We're talking about February, March 2020. It was a new disease, spreading rapidly. And of course, the conversation was, and the question and the anxiety was, will we have enough hospital beds to deal with this new disease? And what should be our intensive care capacity? Next slide, but if you can click one. So if you can remember, at the time we had the Ferguson model that was, as it was called at the time, but let's call it better, the Imperial College model that could actually provide certain broad estimates of what will be the impact of the pandemic, will be the evolution of the pandemic if everything is left unchecked. What will be the impact of non-pharmaceutical interventions like lockdowns and case isolation measures that we're talking about. However, there was an information gap. There were this kind of epidemiological models that were addressing questions at national level, but the healthcare managers and clinicians that I was talking to at the time were working down at the coal face of health delivery. They were interested to know, in our hospital, how much should we consider expanding our intensive care unit capacity? And there were rapid decisions that were required for this, and we ran a couple of modeling studies I will present briefly to you in terms of informing such decisions. Next slide, please. So just a little bit about the setting of these two studies, or in particular the first study, because the second one I will explain why it was more theoretical in nature. So our main collaborators, the Integrated Care Board in Bristol, North Somerset, and South Gloucestershire. You can see hopefully on the map where this is. It includes Bristol and the surrounding areas. There's a population of about 1 million people. It's primarily urban, but there are also kind of semi-urban and rural populations, and also a lot of deprivation within this area. About 16% live in some of the most deprived areas. And the ICBs, they do all sorts of things, but basically commission services. They commission the whole range of services, from urgent and emergency care all the way to primary community health services. The total expenditure a couple of years ago was 1.6 billion pounds. I think nowadays is pushing towards, or probably has even gone over the 2 billion pound mark. So we're talking about some serious decisions and kind of money and funding to go from central government funds to the local healthcare providers. Next slide, please. So the studies have already been published, and the first one was published in Healthcare Management Science, the second one published in Medical Decision Making, and I will go quickly through these two studies. And by the way, a lot of the data and a lot of the models that I'm presenting here today, you can find them on GitHub. They're openly and freely available to everyone to use. So the first study, the one we published in June 2020, it was one of the first modeling studies that talked about hospital level decisions that were published by the time. The local hospital had to answer the question, how many deaths could we expect given different levels of bed capacity? Why? Because they had to decide whether to expand in critical care capacity or intensive care capacity, and whether there is a chance of reducing the number of deaths, and especially the number of capacity dependent deaths. And I will explain what I mean by this. And we actually did the modeling and wrote this paper in late March, early April 2020. So really at the peak of the first wave of the pandemic. And we did inform some decisions that had to be taken at the time. Next slide, please. And if you can click another 3 times, please, Lee. So what we have here is a stylized representation of the model that we developed. We have right in the middle intensive care beds, as you can see, and we have COVID-19 presentations require intensive care. So these are patients already in the hospital that are the condition is deteriorating, and a clinician makes a decision that they need to be admitted to ICU in order to provide life support care. Now, if there are no available beds in the ICU, then I'm not sure. Are you able to see my pointer by any chance?
Yeah, it's perfectly visible.
It's perfectly visible. All right, excellent. So we have the presentations here in the intensive care unit. Now, what happens is, in case these beds are full, then the admission is rejected, and the patient might survive in hospital, or the patient might die. Now, this particular death of a patient who needed ICU and did not have the opportunity to be admitted because of there were no beds available. We call it capacity-dependent death, and it can be mitigated through, let's say, effective planning. It can be mitigated through more beds being available. Then, of course, if there are a bed available, then the patient will be admitted into a critical care bed, and they may survive their stay in ICU, or they might die. This death, we call it capacity-independent death, and you know, the fact that we had enough capacity in our critical care unit didn't make any difference, and this cannot be reduced or mitigated, this type of death, by operations management, if you like, and by building more beds. It can only be improved, this rate, by treatments, by different kind of clinical management of the patient. Next slide, please. Okay, so you know, in terms of demand, we adjusted national forecast. So we have basically the Ferguson model and for the entire population, and we adjusted for the Bristol population in terms of the numbers of patients, the time of patients that will come through requiring intensive care unit. At the time, there is a very good source of information which is called ICNARC. This is basically a federation, if you like, of most intensive care units in England, where they were reporting data before the pandemic into this source. So at the time when we conducted the study, where there were only 4,000 records of patients that had gone through ICU and were included within this database, we only had information of the median and the interquartile range about the length of stay of these patients, but still we managed to fit a very good gamma distribution using only the median and the IQR that was reported by ICNARC. And as you can see, the fitted length of stay distribution of those patients who are in ICU and the medical distribution are very closely matched. Next slide, please. In terms of the probability of death, we could rely on the ICNARC data and the 4,000 records that were available at the time. And we had seen at the time that the probability of death for an inpatient admitted to intensive care was basically 50%. Essentially a coin toss whether one will survive or die following a stay in ICU. In terms of probability of death for a patient refused intensive care admission, that was something that we don't have data. We didn't have data at the time, and actually I will argue probably we don't have data even now. And talking to clinicians at the time, they estimated this probability to be extremely high. They told us that essentially, if a patient with COVID is in hospital and one colleague of ours determines and decides that this patient needs critical care support in order to stay alive, if they cannot get this access to this critical care, then they will die almost certainly. And that's why we set this number very high at 0.99, this probability. Next slide, please. In terms of inputs, we calibrated the inputs to a major tertiary hospital in Bristol, one of the two major hospitals that had an ICU. This hospital typically in normal circumstances had 45 beds within their ICU, so they're quite large in terms of ICUs. And they asked us to test the likely impact of expanding this capacity to 76 beds, because they could do this, and that was the first search level, or to 100 beds, which was the second search level, which is something that they felt that they could also achieve. Next slide, please. I'll go quickly through the results. So we one back, thank you. So these are results. We have a number of we tested a number of scenarios. We varied in the length of stay. We varied the capacity. So what you can see here at the top is that the total deaths can be reduced by 14% if intensive care beds can be increased from 45 to 100. So quite a sizable decrease in deaths. These are the capacity-dependent deaths. If the length of stay were to increase, then they should expect a number of additional deaths, because this is basically reduces the chance of an incoming patient accessing a critical care bed. And we also looked at different levels of demand, depending on different non-pharmaceutical interventions and societal restrictions. And we found that the biggest impact of them all will be actually basically enacting a lockdown. that will be the one that will actually lead to the biggest impact and the biggest reduction in number of deaths. Unsurprisingly, we went into lockdown, and most countries around the world went into lockdown primarily for this reason, not for hospitals and critical care units to be overwhelmed by patients. Next slide, please. So in terms of implications, we test the likely impact of and the potential gain from converting existing clinical areas to intensive care specification, and potential gain from investing in efforts to reduce length of stay, for example, through weaning, when patients kind of are actively supported to not have to be subjected to mechanical ventilation. And one more click, please. Also, we have a number of results where we led to better understanding of workforce requirements. One of the things at the time, what they were telling us, the hospital managers, is that the mortuary was getting overwhelmed. There were so many people dying in hospital that they're having some issues. So through our modeling, we managed to inform them the decision about how much to expand the mortuary, which is quite a grim reality. And so a couple of more points I think I have here, Lee. And also they wanted to know, and we did inform somewhat the decision around the timing and scale of when elective surgeries may resume, because at the time almost all elective surgeries had to stop operating, and we only would do emergency surgeries. Okay, that was the first study. That was a very quick study that we did in April 2020. But then a couple of months later, we actually built up on the first study, and we now answer additional questions with this in the study that we reported in this second paper. So the question was, should access for certain patients be prioritized or restricted? And if we were to do so, how many lives and life years would be saved? And it's something we did, the modeling we did around July, August 2020. Next slide, please. So why triage? Well, some patients, probably you can understand this, is that have a very small chance of benefiting from intensive care. For example, very old people or those with really severe underlying conditions. Not everybody has the same chance of surviving COVID, even if you get the best care available within the context of an intensive care unit. If capacity was unlimited, then no problem, we'll get everybody a chance. But that's the whole idea in pandemic scenarios. Not everybody necessarily is guaranteed access to the required level of care. Another click, please. So when intensive care beds are under pressure, then restricting and/or prioritizing access, which we call triaging, may actually lead to a reduced total number of deaths through admitting those with the greatest survival chances, which, from a logical point of view, kind of makes sense, as well as reducing deaths. So basically increase the number of lives saved. Triage would also increase the number of live years saved, so essentially save younger people, if you like, or give priority potentially to younger people. But as you can imagine, this is all very ethically and philosophically complex and is a sensitive domain. So with our modeling, we didn't want to reach firm conclusions. We just wanted to inform the discussion about whether triage is a sensible way forward when kind of providing critical care to patients in the context of pandemic. The model was very similar. The only difference is, if you can click a few times, please. So the only difference was here, the admission was, oops, one back, thank you. The admission can be interrupted based on triage criteria. And then of course you have the probability of the patient surviving after their admission to ICU, after the care in ICU being disrupted, or they may die. And actually here, the admission can be declined, not only because you don't have enough capacity, but also can be declined because there is some sort of rule-based admission policy that you have implemented, and you will see a little bit more about this later on. So these are type 1 deaths, those patients whose admission was declined based on triage criteria. This is type 2 deaths. These are the patients who started treatment within ICU, but because of some rules, their treatment was interrupted and were discharged. And this is type 3 deaths. These are the patients who went through the entire stay and treatment within intensive care, but they still didn't survive. This is still the case. Next slide, please. So the triage policies we consider was as a baseline, no triage, first come, first served, so identical to the first study in the first model that I presented to you. Then the three policies quickly was one was cutoff. So basically, patients above an age threshold are not permitted access. Tolerance, patients above an age threshold are only permitted access if there are more than one beds available at the time of demand. So you need to have 2 or more beds available. And finally, interrupt. You admit any patient who arrives, provided you have enough beds, but those above a particular age threshold are discharged early upon arrival of someone who is below that particular age threshold, and otherwise wouldn't be able to be admitted. Why we use age? Because that was one of the only proxy that we had actually available to us at the time, and we have improved upon this, as Don will describe and Lee will describe later on. Next slide, please. We use the same model, we just made some adaptations. Nowadays, because as I told you, this is a very ethically charged question, we did it totally theoretically, so we did not model it according to any capacities or specific data that we get from a particular hospital at the time. They didn't want us to do this. And the 2 outcome measures that we used was lives saved, the number of lives saved, and the number of life years saved. So basically lives times the life expectancy if had they not died because of COVID. Next slide, please. Oh, there's another. And we ensure that demand is sufficient to stretch the intensive care bed case, because otherwise, you won't be able to put your triage policies into action. We investigated 3 demand scenarios: unmitigated, lockdown, and cyclical. Cyclical is basically what happened, where we're going in and out of lockdowns and other restrictions. And now, this time around, they have developed a local model for demand, and we use the projections and the estimations from this local model rather than adjusting the national estimates for what the demand might be like. And yeah, that model was at the time in use for weekly projections in the Bristol healthcare system. In terms of, I'll go quickly through this. The paper is there for you if you want to look. So we use ICNARC data again. This is the database that kind of accumulates data from a number of intensive care units around the country. By the time we ran the study, they had almost 10,000 records rather than 4,000 records that we used the first time out. We also use data from the Office of Financial Statistics in terms of calculating life expectancy. And in terms of probability of death if admission was declined or interrupted, again, at the time, we solicited rather in a crude way what the clinicians would tell us that, yeah, if you interrupt the care of someone in ICU, the chances that this patient will die are extremely high. So we use this very high estimation. We have improved upon this, and my co-authors will explain to you later on. Next slide, please. And we've kind of only a couple of slides left. So, obviously there's plenty of results. I'm just going to give you the headlines. So the cutoff triage strategy, that's basically not accepting people above a certain age threshold, had a negligible effect on deaths, but reduces life years lost, because obviously, you favor younger people to the expense of older people. The tolerance triage strategy, so admit if you have enough beds, it gave slightly better results to the cutoff triage strategy, but does restrict the number of patients admitted to intensive care. So essentially, with a tolerance triage strategy, you don't make full use of your bed base. And of course, in the context of a pandemic where there might be times when you don't have enough beds, not using the beds that you have at their full potential, that's not good, as you can imagine. The interrupt triage strategy was the best performing strategy, and we found that life years lost can be reduced by about 12% with some uncertainty around this impact, and that's the 95% confidence interval that I'm reporting there. And any triage benefit is reduced the higher the age threshold is set at. and the triage benefit is also reduced when you have fluctuations in the bed base. So in summary, and that's I think my last slide, for this study, what we learned is that meeting all patients while reserving their right for early discharge can lead to reduced aggregate losses in lives and life years. It makes more effective use of bed availability when compared to other triage methods, with most patients at least having a chance of benefiting from intensive care. And again, very complex ethical considerations, and I'm providing you with a couple of reference there that these ethical challenges are discussed. Next slide, please. I think that could probably is the last one. Yes, so that's the last one. I don't know if you have any questions for me, or whether you want to wait for the end of the presentation, of the whole presentation, and to ask any questions, but I'll be more than happy to answer whenever you want.
Christos, many, many thanks for your presentation. My suggestion would be that we have a Q&A session after all three papers, because then we have a broader perspective. Would you be okay with that?
Oh, yeah, absolutely. I'll be here until the end of the session.
Okay, fantastic. Then who is next after Christos?
Thanks, Christos. It's me. Thank you for summarizing the two studies leading to our project. So one of the issues with discharge policy is that too much focus on the individual patient's attributes on the time of admission, whether it's about the near-term prognosis or other attributes like SOFA score, Apache 2, or their age and other underlying conditions. But very much focus on the patient attributes on the time of admission. The problem with that is that they do not consider the disease might progress during the ICU stay. So, for example, the patients might be admitted when they need a ventilator support, but they will kind of change their level from ventilator to no ventilator, but later on they need a ventilator support again. So there are kind of a trajectory or pathway of each patient, and that change, that progression is dynamic. Further, I mean, the charge policy has been applied or has been hypothetically proposed in the literature also ignore or do not consider the combination of the patient has been admitted to ICU, and also as well as the uncertainty in terms of incoming patients that might become critically ill in the foreseeable future, especially with the pandemic under this kind of extreme stress or pressure. More importantly, we know, I mean, from the paper in the medical domain or journal outlets, we know that for the resource rationing, especially for rationing the critical medical resources, there's a principle of fairness, and for the principle of fairness to uphold, there need to be kind of 4 pillars has been talked about and widely kind of observed in the agreed in the field. The first one will be maximizing the benefits produced by scarce resources. Second one, treating people equally. And third one, promoting and rewarding instrumental value. And finally, giving priority to the worst off. The worst off could be understood as the most sickest or the younger group of people who will live the shortest life if they are left untreated. So the reality is very few policies have operationalized all those 4 values at the same time. So our project tried to address these 2 limitations I kind of presented here. So that's kind of intention. Okay, so for the problem, actually, it's the problem Christos mentioned. It's the most controversial one. So imagine a critically ill COVID-19 patient arrives to be admitted. However, all the beds are occupied or the ventilator has been utilized. So what the consultants can do is basically rejection or admit this patient, but at the price of early discharge an existing patient. So that's exactly the interrupt strategy Christos mentioned in their previous paper. Well, as I said, that's the very controversial one, because early discharge or discharge prematurely will cause lots of mental stress. Imagine, and also to the doctors, to the nurse taking care of the patient, as well as to the patient's family. So those physicians or nurses may have developed an emotional attachment with this existing patient. But equally, if we reject a later patient who has a clearly better chance of survival, will almost die if left untreated. So it's a very difficult decision. It's literally life or death decision, but we are not trying to play God here. Basically, what we try to do is try to develop a systematic approach to the problem and try to provide some decision support under such situation. So this is our approach. We will formulate the problem as a Markov decision process. I will explain or have a very quick summary about what do I mean by Markov decision process in the next slide. We also got the data at a very granular level from one of NHS Trust, and we try to build Markov chain transition matrix to show the progression of ICU patients during their stay. One of the problem with the MDP or the problem formulated is as an overarching problem is we can't solve it optimally, find the optimal policy. So we go around and try to decompose the problem and try to derive the index policy analytically. Then we carry out quite comprehensive simulation studies. Don't welcome to present the results to evaluate the performance of our index policy as compared to other benchmarks. For example, those interrupt strategy and those first come, first serve kind of strategy. And during the whole project, we have open dialogues and conversation with health professionals. We conduct the questionnaire survey from those ICU consultants for their inputs to our model. And we also try to disseminate findings and to influence policy. This talk is one of those endeavors. Okay, so that's the model. The intentions is not try to bombard you with lots of math. However, I think it will be quite beneficial try to explain what the model look like, how we operationalize those 2 or 3 values that I mentioned at the beginning of my talk. Okay, so the Markov decision process, we first think about the problem. Okay, the problem has kind of a limited time horizon. Okay, so every pandemic has a limited time, thankfully. So it's a finite time kind of decision, Markov decision process. Then we try to break down this big T, the whole time period, into a smaller T that allow in that each small intervals that at most one patient arrives. Okay, so that's what we call it as a time epoch or time horizon. Then in the Markov decision process, we need to have the key element will be the state variable, and that is try to describe the combination of patients that has been admitted to ICU. So for example, we probably have 8 young people and 12 older people has been admitted to the ICU units. And out of them, there are 60% of them require invasive mechanical ventilator, for example. So the best way to show that state, show that combination, is try to use the category, the younger and older, that characterized by the K, and also whether they use ventilator or they just use the mask, the supplementary O2, that will be captured by the severity level L here. Okay, so the state variable is trying to capture these two dimensions, the combination of the patients already admitted. Then in this whole problem, we try to find a policy. The best policy is try to minimize whatever the cost or maximize the value, right? And that policy will prescribe action, okay? The action in this case is either admit a patient or reject a patient based on the criteria, or we do nothing if the bed's full, or early discharge a current patient. That has been described by the action set A here. And as a Markov decision process, we know it's a dynamic, it will evolve. We clearly need transition probabilities. Okay, so the mass is not here, but we have the formula to calculate that transition probability. But the most importantly, we know in such a problem, once there's action, there will be consequence, right? That has been captured in this Markov decision process. So the consequence here, once the patient's either admitted or rejected or early discharged, it will be captured by this cost, so-called one-step cost. Okay, it's the consequence of our action. I just quickly, I think it's useful to show we have captured those expect life year lost in the next time period in the first term here. The second terms to capture the cost have been lost if the patient has been rejected or early discharged. And the last term, we introduced this parameter H, that is the early discharge penalty, okay, to penalize if the patient is early discharged rather than rejected. By introducing this early discharge penalty, we kind of serve the principle, or one of those pillars, assigning a certain value, the instrumental value, to a certain group of people. The certain group of people in our case is those existing patients, as we kind of described. It's create a lot of stress to early discharge existing patient as compared to reject the new patient directly. So that's the value of H. Then overall, what we try to do is try to find that policy pi, okay, which subscribed action. That policy will help us to minimize the expect life year lost over the whole time horizon T. Okay, that has been expressed by this equation here. So it's accumulates odd step cost during the first time period T minus 1, then there will be last element of time T when everything shut down. That's the end of the time, and we calculate this at the cost at that time. Okay, so the problem with try to find this optimal policy is that because we have a very large action or state space, so it's not computationally viable, even within dynamic programming by using the Bellman equations. So we try to go around this by using decomposition. Okay, the decomposition is now imagine the patient arrival, each individual arrival, then we not only need to make a decision about admitting the patient or rejecting patient, but also at what level that patient will be discharged. Okay, so the underlying assumption for that is the patient will only be discharged when their condition is improved. In doing that, we need to introduce a very important key lever that is called the bed usage rate W to deriving our index policy, workable policy. By using this bed usage rate, the total number of beds are relaxed. Okay, in a way, we can increase the bed usage rate if the bed is, we need to have a capacity issues, right? And lower down the bed usage rates if the capacity is no longer the problem. And also the bed usage rate W has kind of two-side value, like a coin have two sides. It has a system value, okay, that basically decided by the demands, the arrival, as well as the bed occupancy rate, and also the shadow value. The shadow value is each individual patient, they have a maximum kind of threshold to compare their value with the system value, in order to see if it's worthwhile admitting this new individual, this new patient arrival for admission. And that shadow value, as we show here, it should be determined by the relative benefits obtained from her ICU stay, from ICU treatment, as well as her length of stay. So the bed usage rate W is a rate, depends on the length of stay. So the longer the patient stay in the ICU, the greater the cost, right? So basically, it's quite straightforward to show if we increase the system value, system W, okay, the bed usage rate, then the index policy we derived are more likely to reject a new patient. And when the system W, the value equals 0, then no patient will be or shall be early discharged before their actual time. Either they will be recovered, discharged to general ward, or they unfortunately die in ICU. So that's kind of thoughts behind our solution methods to come up with our index policy by using decomposition and focus on single patients, and not just focusing on admission and rejection. We also try to decide at what level they should be early discharged, depends on their shadow W value. Okay, so that's the meaty part. I look into time. So now let's talk about the data. We very fortunately, by working with the University Hospital of Bristol and Western, we get to the data from the ICU. I mean, the two intensive care units between the time period of March 2020 to December 2021. So that time period covered two big waves of the pandemic peak. Okay, so this is, the table shows the data summary. We have break down the patients into two groups, two age groups. So above 60 and under 60 years old. And the data shows actually the mortality or the death rate is clearly, I mean, the age clearly play an important role on the death rate for during that ICU treatment. So there's 48% of people unfortunately died for over age 60, and only 19% of people died under age of 60. And you can also see that age does not play any kind of differential kind of effect on the length of stay. It's a pretty similar for two age groups. I will cover this first mode of ventilation. Yeah, in the next slide. Okay, so one of the key reasons we needed those granular data from ICU units is that we tried to build this Markov chain transition matrix to show the disease progression for the patients during their ICU treatment. So this Markov chain illustrated here has two absorbing states. Okay, the green 0 means they have been fully recovered, can be discharged from ICU, and the dark one is a death. Okay, so for example, if the patient come into the ICU with a severity level 1, and during their stay, it's most likely they will stay at level 1. Okay, however, there's also a small chance they might be discharged, or their condition deteriorating, and they become level 2 patient. Okay, and so on and so forth. So this is a kind of Markov chain transition matrix we try to develop and as a key input to our simulation study. In order to build that matrix, the key thing is we need to decide how to assign the level to each patient. In our study, we use the type of breathing support provided for patients to track the progress of patient disease while in the ICU. The reason for that is we have the data, hourly data available in our data set. And there are other studies using other kind of SOFA score approach to characterize different severity levels. However, that data is not readily available in our data obtained from the Bristol Hospital. And they're also using some other markers like C-creative protein. Again, the problem with that is we do not have a clear threshold to separate different level, different severity of the patient. Okay, so these are the two tables that we summarize all the transitions from these 4 types of breathing support. A stands for room air, sub O2, supplementary O2, just using the face mask, non-invasive ventilator, and invasive mechanical ventilator. So basically, those are the kind of stages that show the severity of the disease, particularly for the coronavirus disease. So we calculate all the transitions from and to a different mode of breathing support and summarize these 2 tables for the patients over 60 and patients under 60. Okay, so underlying kind of thinking is for the older people, the transition will be different from the younger people in a way that disease, how the disease will improve, their condition improve or deteriorating will be different depending on their age group. So before we work out the probability, we just do some kind of a little adjustment, try to combine the room air with supplement O2 together, because the cases, if you see, is quite small here compared to other 2 types of breathing support. So it's also in line with the literature, the 3-stage model, to describe the severity of the patient with COVID. Okay, so these are the probability we derived. So this is a big chunk of the input to our simulation study. Okay, so I probably have 5 more minutes. Okay, so just revisit the graph from Christos' paper. one of the thing we try to work out is the death probability or the mortality. So we probably use different notations here, but nonetheless, it refers to the same thing. The type 3 death, which is within ICU death, it's psi or phi. Sorry. So this kind of probability can be worked out pretty straightforwardly from our Markov chain matrix, okay, as well as the length of stay for each patient, as long as we know their group and their level when they arrive. However, the issue with the Christos paper is that they assume this two probability, two death probabilities to be 0.99, which is, I know there's some conversation going on between the consultants and in the research team. However, we think we need to do a kind of more in-depth investigation about how we should estimate those probabilities and whether the probability of rejection and probability of early discharge has the same value or not. Okay, and that's why we conduct our questionnaire survey and try to work out what is the motility of rejection, as it is rarely reported in either literature and practice, as echoing what Christos said. So the way we try to approach that is we work out what is the relative risk. Okay, we find out the ratio, try to. And because we know psi, that's the death probability within the ICU. So as long as we know the ratio, we can work out the mortality of rejection, okay, by using this formula. So that's the kind of rationale to use questionnaire as an instrument to investigate among the ICU consultants who have a lot of experience and expertise, try to ask them to estimate what is the kind of probability of death when the patient is being rejected or early discharged. So after quite a few rounds of correction and force backwards, this is kind of a questionnaire we finally finalized and asked the ICU consultants to fill in. So basically, we have kind of two scenarios for the ICU consultants to estimate the probability. We used a single COVID patient to condition that the estimation of the doctors, the consultants or physicians. So basically, the scenario 1 is about the rejection mortality, and scenario 2 is about the early discharge and mortality. Okay. Right. So this is the results we got from our questionnaire. Overall, there are 11 responses collected from the ICU units from the University Hospital of Bristol and Western Trust, and 10 of them are consultants, and 1 of them is advanced trainees, and all of them, on average, they have more than 10 years of experience in ICU units. So they have quite good sense, I would say, about over the year, about what will be the probability of death if the patient is being rejected, or that's the scenario 1. And hypothetically, if the patient's being early discharged, that's scenario 2. So we also asked 3 different beliefs in the questionnaire: most likely scenario, optimistically, and pessimistically. Okay, that's shown as a color, the blue, orange, and green. So from this graph, you can see the RR, the ratio of the deaths of admission over the deaths of rejection. And the blue one, the most likely scenario, is almost identical, 0.63 to 0.64. Although we can see the range in terms of the optimistically and pessimistically is the scenario 1. Scenario 2 is a bigger. The interval is bigger than the range when the consultants were asked about the rejection death probabilities. The reason is quite, I mean, this is quite well expected, because this is scenario 2 with early discharge. It's hypothetical. It probably never happened in their practice. So that shows that also the standard deviation of their kind of estimation is higher in scenario 2 than scenario 1, to show how they are not very consistent among those 11 consultants. They're not very consistent or very confident about their estimation. But nonetheless, what I try to say is it seems the RR ratio for both scenario, rejection and early discharge, are similar. So that's why in our simulation study, we will use the same value to capture that. Okay, so this is probably my last page. It's a quick summary of what, I mean, about my part of talk. It's actually the modeling approach and the decomposition method actually, as I described, have operationalized the first 3 values underlying the fairness principles. So by relaxing the bed capacity using bed usage rate, we are able to treat every people equally, right? Regardless they arrive early or late. In a way, they need to be decide when they can be early discharged based on their own kind of relative benefit can be obtained from ICU treatment. So all those 3 values, I think in our modeling approach, in our decomposition method, has been operationalized. The final one, our numerical results will kind of back up to see whether or if our index policy help with those worst off. Second key kind of headline will be our index policy development is kind of forward-looking in nature. They are not just focusing on the single patient at time of admission. We consider the disease progression. We consider the combination of patients has been admitted in the ICU unit. We also consider the demand. The third key finding is that the patient data from this particular trust is in great alignment with national data from ICNAC. So the average patient age is about 57.7, and also a similar kind of mortality for different age groups. And next one is the Markov chain calibrated, actually provides a quite reasonably accurate model for our disease progression from the key parameters we calculated. That's also in line with the real data. And finally, the relative risk we try to derive from the questionnaire among the consultants provide a good base to assign patient mortality of rejection and those of early discharge. So yeah, that will be the quick summary of the approach and the models and the data we have been put through in the project. And Now I will leave the space to Dong to present the results from our simulation study.
Okay, so thank you, Lee. Can you hear me, by the way?
Yeah.
So I will now,
clear.
yeah, so I will now ready for some numbers. So can you move on to next page, please, Lee? Right, so this is kind of a similar simulation as Christos mentioned early on. We use some similar kind of strategy here. For example, we include first come first serve as a baseline strategy, which doesn't do any triage. If a patient arrives, there is bed, then they have been admitted. Otherwise, they have been declined. Nobody is being early discharged. So that is the kind of benchmark, first come first serve. Second strategy is what Christos mentioned as well, which is they call interrupt in their paper, but we use the same name here. Again, all patients are admitted if there are any available beds. But if the SU is full, and then what happens is this: so if any of those further below this threshold could be discharged upon the arrival of a patient which is close to the threshold. And here we use a different definition of threshold. Rather than using the age, we use extra life years saved if a patient being admitted compared to being declined. So basically, it is the extra benefit by being treated in the ICU rather than being declined. So this is different from the previous interrupt. In essence, they are the same kind of idea. The last one is our proposed policy we call index policy. Lee has mentioned a lot of kind of modeling and the mathematics behind this policy, but in the high level, we calculated a numerical score, which we call it an index for each patient. And here we consider the penalties for early discharges, which are not considered in either of the previous policies considered or any in the literature. So no, as far as we know, very few research have considered the penalties for early discharges. And this policy works as below. So again, if there are still available beds, anybody arriving will be admitted. But otherwise, then we compare the index values between all the patients, so those within the ICU already and the new arrival. By the way, in the simulation, we consider a single arrival at a time because we have a very small time interval, which is 1 hour long time interval. So every 1 hour, we can assume reasonably at the most one patient would arrive. Therefore, we compare all the index values between those already in the ICU at the moment and the new arrival. And then the one with the highest index value, if that is someone in the ICU, then they will be early discharged. Otherwise, if the new arrival has the highest index value, then they will be declined admission. So this is how the index policy works. Now we can move on to next page, Lee. In the simulation, which is very similar to the previous work, we use the similar demand curve, but we focus on the lockdown curve in this presentation. and we consider in total over the 1 year time. By the way, we scaled down the number of arrivals to allow faster simulation. So we scaled down the number of arrivals to 185 over a year, which means almost kind of 2 arrivals per day. We consider 6 beds available in ICU, which again is a theoretical number, but we try to make this beds small enough so that the demand stresses the ICU beds capacity. In this simulation run, we use the 0.5 as the penalty for each single discharged patient early. And 0.5 is just a control variable. It doesn't have any actual meaning. Essentially, the larger the penalty, the less discharges would be recommended by the policy. For example, if the penalty is 1,000, for example, then there won't be any early discharges being recommended by our index policy. But if the early discharge is 0, there would be a lot of discharges being recommended in our policy. We repeated the simulation for 500 times when we report the average results in this presentation. In the middle is the table which gives us the input data in quite granular level. So we have two categories. We have under 60 and 60 plus. Remember that in the previous slides from Lee's presentation slides. And we have 3 levels. The first level, which is the least serious, is the support O2 plus RA, and then the middle level is non-invasive mechanical ventilator, and IMV is the most serious level, which is invasive MV. And the left is remaining is actually derived from the previous studies data. So we just aggregated them for different age groups. Therefore, we have 35.5 years remaining for under 60s on average. We have almost half of the life years remaining for the 60 plus. Last column shows the demand proportion. So how many patients, when they arrive, they belong to each category and each level. For instance, for the under 60s, 25%, 0.9, would need the NIMV upon arrival. And also for the 60 plus category, 23% would need an NIMV upon arrival. And the last two tables shows the Markov chain, which rather than a graph, we give the detailed probabilities from one level to the next. Just to give you one example. If you look at the first example, top table, category 1, level 2, so it has, because we have a very small time interval every hour, we check the transition. So it's most likely within 1 hour time, they will remain the same level. For example, from 2 to 2, it has 90% chance they remain where they are. And there is a small chance they will improve to level 1. And there's another even smaller chance for these patients to move to a worse level, which is level 3. So you can see the table gives us all the transition probabilities from one level to the next. And these are all the input data we use for our simulation. So now let's move on to the results page, which is my second last page. So let's focus on the left-hand side first. The RR value is 0.63, which is the one we obtained from the questionnaire. For this scenario, we reported, so for the 3 different policies, we first report the total deaths. As you can see that in terms of total deaths, there are not big differences between the 3 policies, to be honest. So first come, first serve leads to 81 deaths overall, and interrupt is the best one, which leads to 77. Four people, 4 lives lost less due to interrupt, and our index is in between. It's close to interrupt, but still the difference is not too huge, which is in line with the previous results. And then if you look at the by categories between 60s and below and above 60, then again the difference is not too much different between the 3 policies. Now if we move to the last row, which is a left is loss, then we can see the more difference between the policies. And remember, our objective is to try to minimize the left is loss in total, which basically we prioritize the younger people, which has a much longer left is remaining. As you can see here, the interrupt achieved much less left is loss compared to first come first serve. So it's 50 years almost less in this simulation, and index is similar to the interrupt, slightly more, but still much less than the first come first serve. And now if we move to the third, sorry, it's still the first table, but the third block of the table, the total early discharges. Of course, first come first serve doesn't recommend any early discharge, so they have 0 number of early discharges. between the interrupt and the index, we can see interrupt propose much more early discharges than the index. In this example, they have recommended 40% of people being early discharged after they have been admitted. So you can see, going back to the issue we mentioned on early discharge is a difficult issue to face with. Therefore, the one potential pitfall of interrupt is they must propose a lot of early discharges, even they are able to achieve the best left years lost. So now if we move to the right-hand side table, we have reduced RR to 0.4, well, which means that if a patient is being declined admission, in this scenario, they have a higher chance of death compared to the left-hand side table. Okay, so in this scenario, if we compare the first block of results, the total deaths, you can see that the first come first serve achieves even less number of left lost compared to index. And if we dive room into the by categories, they have so between these two categories, you can see first come first serve has led to much more left loss for the younger group compared to index. Even they have achieved less left loss for the older group. But now if we go to the last row here, you can see if we compare the left years lost, even the first come first serve have the same number of life lost, they have led to much more left years lost because for index they saved more younger people, then they saved more life years lost. Again, between the interrupt and the index propose much less early discharges compared to the interrupt policy, even though interrupt does again achieves the least amount of life years lost. So in summary, interrupt is best if we only look at the number of left lost and the number of left years lost. But the problem of interrupt is they propose too many, maybe far too many early discharges. So this is kind of the whole picture of the results. Now I have two more results to show before we go to the conclusion. And this picture shows the bed occupancy over time between these two policies. A quick takeaway of these two graphs: if you compare the areas, the area between the green line and the blue line, the green line and the blue line, the area shows the beds allocated to the level 3 patients of the category 2. Clearly, you can see the area is larger for the index policy, which means that index policy allocates more beds to the most serious patients than the first come first serve, and the less beds are allocated to the less serious patients in the same category. Now, if we move to the next slide, Lee, so choose. Oh, this is the wrong page. We have a curve showing the overall. Yeah, this one. So this one is the overall kind of bed occupancy across all the categories and the levels by time. You can see that this is a difference between the index and the first come first serve. The positive value shows higher occupancy by index. The negative value means the lower. Means the high occupancy by first come first serve. Clearly, we can see more positive values over time, which shows that the index leads to more or higher bed occupancy over time compared to the benchmark policy of first come first serve. So Lee, can you move on to my last page? The key messages to take away today from this presentation from my part is that first come first serve leads to the highest lives or left years lost, which is in line with the previous results. And interrupt strategy leads to the least losses, which is again aligned with the previous results, but they are at the price of a lot of early discharges, premature discharges. And I think the benefit of index policy is they kind of achieve the balance between these two policies. So they achieve fairly, I mean, lower percentage of early discharge, and still achieves quite a good amount of lives lost and life years lost. And also, as the RR ratio decreases, then more younger patients, more younger deaths can be avoided by applying the index policy. And also between the bed occupancy between first come, first serve and index, we found that index policy leads to higher bed occupancy over time, and more beds are allocated to higher or more serious patients under this policy. I think that's all I have for this presentation. I think now we are ready for some questions if there are any from the audience.